So the first topic which we are going to discuss is nephrotic syndrome. Okay. So can anyone just tell me what is nephrotic syndrome? Anyone? Hello? Hello?
Yes, in nephrotic syndrome, there will be there will be the podocyte damage, and because of that damage, the barrier will break down and the protein will be lost in the urine. So there will be proteinuria more than 3.5 gram.
Perfect. So the main hallmark for nephrotic syndrome is that we are going to lose proteins, right? Proteins. So the protein are going to be lost in the urine. Okay, that's the main hallmark of nephrotic syndrome. While on the other hand, the main hallmark for nephritic syndrome is that we are going to lose like some of amount of protein, but it's more concerned about inflammation going on. So we are going to see red blood cells, okay, or blood within the urine. These are the two things how to differentiate. Like for example, on your USMLEs, whenever you see an MCQ that just marking that we are having some traces of red blood cells, so that is going to be nephritic syndrome, not nephrotic syndrome. Okay, so these are the main things. So there is a standard number which is given that is greater than 3.5 grams per day when protein is lost in the urine. That's simply known as nephrotic syndrome. Okay, so before discussing nephrotic syndrome and its different types, we already know that we have a barrier, right? We have like our basement membrane. Upon the basement membrane, basically we have a foot-like processes which are known as podocytes, right? And these podocytes itself have a negatively charged barrier, if you guys remember, right? Which was barrier of heparin sulfate. Remember? Hello?
Yes.
Yes.
Okay. There was a barrier of heparin sulfate. We all know that the proteins basically contains a negative charge, right? Proteins have a negative charge present on itself. How? Because the proteins have a phosphate group, right? And that's negative. So whenever in a normal individual with an intact heparin sulfate barrier, whenever the protein approaches here, okay, we have endothelium which have fenestration, right? Fenestration are like, the big spaces present between the endothelial cells, right? So whenever the proteins in a normal individual come towards this barrier, what happens? As the proteins are negatively charged, heparin sulfate are negatively charged, so negative and negative repel each other, right? Am I right? Hello?
Yes.
So we are going to have negative repulsion, and in that way, the protein is avoided to being lost in your urine. Is that clear? Hello?
Yes.
Okay, perfect. So whenever this negatively charged barrier is lost, now you do not have anyone to repel your protein. So in that case, the proteins are going to move out in your urine. Okay, that's the main concept behind your nephrotic syndrome. So for example, if you are losing proteins, right? So for proteins, the plasma proteins are of different type. All of us know, right? We have albumin, right? We have albumin. For example, if this negatively charged barrier is lost and we are losing albumin, right? So whenever we are losing albumin, we already discussed that albumin is a good osmol for your blood, right? For your blood vessels. And we know that it's the ability of osmol is to keep fluid with itself, right? So if we are losing albumin, it means we are losing osmoles, right? Or we are losing those solute particles. If you are losing osmoles, it means that now the fluid won't remain inside your blood vessels. So what would happen? The fluid is going to leak out into the interstitium, and that's known as edema, right? So can I say that nephrotic syndrome would lead to pitting edema? Yes.
Yes.
Okay. Another thing, we know that we have immunoglobulins, right? Immunoglobulins are also proteins, right? They are protein particles. Normally, they keep on roaming around here and there in your blood, right? So in this case, they are negatively charged. Again, when the negatively charged heparin sulfate is lost, what happened that our gamma globulins are also going to be lost in your urine, right? So we are going to have hypo gamma globulinemia. Okay, so in that case, if we have less gamma globulin, so don't you want to think that we are going to have increased risk of infections? Yes, because you are losing, your antibodies, and antibodies are really important in order to fight against a pathogen because they are going to undergo a lot of processes which we are going to discuss in our immunology section. They are going to undergo opsonization. They are going to tag all of the, encapsulated bacteria and everything. So whenever we have less amount of gamma globulins in the blood as a result of nephrotic syndrome, it's going to lead to increased chances of infection. What else? If you guys remember, we have a factor. We'll be discussing that in our hematology section. That is antithrombin 3. What is antithrombin 3? As the name indicates, it's an antithrombin. It would avoid the formation of a thrombus. Normally, it is present in our body in order to look for the activity of thrombus formation. If the thrombus formation activity is exaggerated, this natural molecule is going to stop the formation of thrombus because it's antithrombin, right? So that's also a plasma protein. It's present in the plasma. So sometime in case of nephrotic syndrome, we can lose antithrombin 3 as well. So if you have no one to keep check on your thrombus formation and your thrombus formation is exaggeratedly high, so won't you think that there would be a hypercoagulable state? Hello?
Yes.
Yes.
Perfect. So we are going to have hypercoagulable state. Okay. Another thing which you should just keep in mind. For example, if you're losing albumin, right? So we know that all of, like nearly most of these plasma proteins are made by your liver, right? Okay. So what your liver is going to do, like you can simply think of, if you are removing osmol from your blood, it means you're making the blood thin, right? The viscosity of blood is going to become very less. But in order to restore the amount of albumin again from the liver, it takes 21 days for that, right? But we cannot wait for 21 days. We cannot let your blood stay thin for 21 days. So what your liver is going to do as a compensation of that, it already have a big reservoir or stores of lipids, you guys know, right? So what would happen, your liver is going to start dumping off your lipids and cholesterol into the blood in order to give an attempt to restore that lost viscosity. Does that make sense? So the acute compensation for loss of all of this protein is going to be your liver dumping off lipids and cholesterol, right? So in nephrotic syndrome, won't we be seeing hyperlipidemia and hypercholesterolemia? Am I right? Hello? Hello?
Yes, you're right.
Yes.
Okay. Please just do participate, okay? Also. So let's discuss our first pathology that comes in, under the category of nephrotic syndrome. The first pathology is minimal change disease. Okay, so I'll just tell you the best ways to memorize each and every pathology if you guys are following and if you guys are participating, right? So what is minimal change disease? You should just keep in mind minimal change, right? First of all, it's a mini, right? And mini stands for small, right? Small children. So it's a nephrotic syndrome which is seen in small children, mini, right? For from the word mini, you should just keep that in mind, mini, right? For small children. Minimal change. What does the minimal change mean? It means we are going to see very less change in this pathology, right? Less change. And what's going to be that less change? Yes, we are only going to see loss of albumin, not loss of, gamma globulin, not loss of antithrombin, not any loss of, other plasma protein, but only the albumin is going to be lost. So looking towards the name, we have two things in mind: minimal change disease. We are going to have minimal change. Mini stands for children. It's going to be a nephrotic syndrome seen in children, right? The most common cause of, the nephrotic syndrome in children. So basically what happens in this pathology, so let's again go into the structure of your glomeruli, right? The filtration barrier. We discussed that we have a negatively charged heparin sulfate barrier, which is normally present at the podocyte processes, right? So it's a heparin sulfate there. Okay, so what happens in minimal changes is, just keep that in mind, it's associated with Hodgkin lymphoma, right? What do we see in Hodgkin lymphoma? If you guys remember, we are going to be having certain characteristic cells which are known as Reed-Sternberg cells, right? Reed-Sternberg cells. We are going to discuss that in detail in our hematology section. Those Reed-Sternberg cells basically make a lot of cytokines, right? And those cytokines in turn recruit a lot of inflammatory cells into a lymph node, which is going to lead to enlargement of lymph node, and that's why we call it as lymphoma, right? So these cytokines, when released into your blood, they are going to go into your kidney, into the filtration barrier, and these cytokines are going to lead to effacement of these podocyte processes. So what do I mean by effacement? These podocyte processes, which were initially, a foot-like processes, now they are going to become effaced. Okay. Okay. And this effacement of these podocyte process is going to lead to loss of negatively charged barrier, that is heparin sulfate. So if we are losing that negatively charged heparin sulfate barrier, why? Due to the presence of cytokines. From where do the cytokines come? Most probably from Hodgkin lymphoma. So what would happen as a result of that? It would lead to effacement of the podocyte processes, which is going to lead to loss of that negatively charged barrier. And as the negatively charged barrier is lost, what would happen? All of the plasma proteins are going to again leak from your food process. But since it is a minimal change disease seen in children, and we are going to be having a minimal change, that is, only the albumin are going to be lost. Only the albumin is going to come out, it's going to be lost. Is that clear? Hello?
Yes, yes.
Yes. Okay, perfect, right? So on H&E stand, we won't be seeing like, we are going to see like lipids in the proximal tubules, right? So we know why are we going to see lipids there, because whenever we are losing albumin, it takes 21 days for the liver to restore albumin. So in that case, we are going to see a lot of cholesterol being dumped out into the blood from your liver, because that's already present, right? We have a big reservoirs of cholesterols. Okay. What else we are going to see? We are going to have effacement of food process on electron microscopy, right? Because light microscopy cannot, visualize that this small barrier. So it's only going to be seen on electron microscopy. We won't be seeing any immune complexes deposition. I'll be telling you what are immune complexes deposition and how do it lead to problems, right? But here you should just remember. Okay. So selective proteinuria, that is only albumin is going to be lost. Okay. So what's the main culprit which is causing this problem? What do you guys think? The main culprit? That's your cytokines, right? Hello?
Yes.
So what do you guys think? Would the steroid administration help this individual? Yes or no?
Yes,
Yes,
yes.
because if you are suppressing the immunity, it would
Mm.
help this individual. We are suppressing the cytokines. If you are suppressing the cytokines, it means there won't be any, effacement of the podocyte process, and in this way we can help this individual. Is that clear? Hello?
Yes.
Okay, perfect. So let's move towards our next pathology. That is, okay, if the same effacement of food process is seen in adults, right? Just keep that in mind. It's the same effacement of these podocytes are seen in adults, right? And the etiology is different. We basically name it as focal segmental glomerulosclerosis, right? Focal segmental glomerulosclerosis. So first of all, let's break down this name. Focal. What do we mean by focal? Yes. Focal
Yeah.
basically means that some glomeruli are going to be involved, right? And for example, the word focal means that some glomeruli are going to be involved. If you have, let's suppose, a total of 100 glomeruli, so the word focal means that only a specific 2 to 3 glomeruli are involved, right? Okay, what do we mean by segmental? Not every part of your glomerulus is going to be involved. Only specific part of your glomerulus is going to be involved, right? Either it can be afferent, either it can be efferent, either it can be the capillaries. Okay. Hello.
Yes.
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 Focal,
Mhm.
segmental. Focal means some glomeruli, segmental, some segments of the glomeruli are going to be involved. What are going to happen? What kind of involvement? This name just told you. Glomerulo, the glomeruli is going to become sclerosed. What do we mean by sclerosis? Thickening, right? So focal, segmental, glomerulosclerosis. That is like some of the glomeruli are going to be involved, some of the glomeruli are going to be sclerosed, and not only some, but a specific parts of glomeruli are going to be sclerosed. So can anyone just tell me what do you mean by focal segmental glomerulosclerosis? Can anyone just tell me again?
Some of the glomeruli and these only the specific part of the nephron will be affected. Will be getting sclerosed or thickened.
Okay, that's perfect, right? Sclerosed and thickened. Again, the same thing happens in in focal segmental glomerulosclerosis. What same thing? Effacement of podocyte processes. But this time, the effacement, the culprit behind effacement of podocyte process, they are not your, they aren't your cytokines, right? In case of minimal changes, you were seeing that cytokines are basically responsible for effacement of these podocyte processes. But in case of focal segmental glomerulosclerosis, usually it's idiopathic. We do not know the cause, but sometimes it's associated with HIV, it's associated with heroin use, it's associated with sickle cell disease, right? Keep these three things in mind. What? It's sometimes associated with, okay, mostly we are going to see it in Hispanics and African Americans, right? So this kind of pathology is mostly seen in Hispanics. Okay, you're going to be having an MCQ on it as well. They're going to ask you the etiology. They're going to ask you that in which kind of individual do we see this in this pathology. So that is Hispanics and African Americans. Okay. What else? It's basically idiopathic, but the involvement is most common, like most commonly seen in those individuals who are having any HIV, any heroin abuse, or sickle cell disease. Okay, that's an important thing. Okay, so what are we going to see? Again, we are going to have effacement of food processes. Okay, but no immune complexes are going to be seen. I'll be discussing the immune complexes concept in a while, but here again we won't be seeing any immune complexes, right? So I'm asking from you guys, if the same pathology, focal segmental glomerulosclerosis, that is effacement of the podocyte processes, but now it isn't due to any cytokines, right? The etiology is idiopathic. We do not know the cause, but we know the association. It's associated with HIV, it's associated with the heroin use, it's associated with sickle cell disease. It's seen most commonly in certain group of individuals. So what do you guys think? Would administration of steroids help this individual? Yes or no?
No, no.
Less
Why?
effective, no effective, yes.
Yes, yes.
Why?
Because there is no etiology of some inflammatory process or
Yes.
cytokines. Yes.
Okay, and another thing which you can remember, if this individual is already having HIV, heroin, sickle cell disease, his immunity is already low. If we are giving further steroids, we are worsening the condition, right?
Yes.
Does it make sense? Hello?
Yes.
Yes.
Perfect, right? So this was all about focal segmental glomerulosclerosis. So you are going to be asked MCQs regarding it. Like it's going to be simple. What do you mean by focal that is specific foci? They are going to ask you in which kind of group of individuals we are going to see it. They're also going to ask that would the steroid administration help or not. Okay, so the next pathologies which we are going to discuss is, okay, before discussing those pathology, I want you guys to memorize one thing. Okay, if you guys know this, you're going to easily tackle the other pathologies which I'm going to discuss in a bit. Okay, so whenever you see the word membranous, whenever you see the word membranous in any kind of nephrotic syndrome, right? What you are going to assume, you are going to assume two things. The first thing is that you're going to assume that there would be some thickening of the basement membrane, some thickening of glomerular basement membrane. What else you are going to assume? You are going to assume that this is always going to be due to deposition of your immune complexes. Okay, so let's discuss that how does the immune complexes lead to problems. That should arise in your mind. Okay, can anyone just tell me what is immune complex? What is immune complex?
And
It's a
combination of
combination.
antigen and antibody.
Okay, whenever we have an
And
antigen,
complement.
right? Whenever we have an antigen, normally, your antibodies are going to come, it's going to tag that antigen for destruction, right? This process is basically known as opsonization, right? Like the antibodies are going to be produced by your B cells. They're going to tag the antigen, and collectively it's going to form an immune complex, right? Immune complex. Is that clear? But sometimes what happens, okay, so whenever the immune complexes develop, start building inside your blood, so it's basically the goal of your complement, it's basically the goal of your complement system to destroy these immune complexes, right? But sometimes whenever we have failure of this process, like for example, if whenever we have complement deficiency, right? You guys know the SLE, systemic lupus erythematosus, we have a complement deficiency, right? So whenever we have complement deficiency, so these immune complexes are going to build up, right? And once these immune complexes build up, they are going to deposit in different tissues deposition, right? Are you guys getting me? Hello?
Yes.
Okay, so sometimes they can just come into your glomerular membrane as well, right? Glomerular membrane, right? Or the glomerular, the barrier, okay? Okay, so what happens whenever they get deposited in the glomeruli or in this filtration barrier, these immune complexes, so what they are going to do, they are going to activate they're going to activate the local complement system, right? And as we know, the local complement system, which is basically present at the level of tissues. So what that complement system is going to do, it's going to become activated, but it cannot remove these immune complexes. So what would it do in turn? It would lead to destruction of this barrier, right? And as this barrier is destroyed, now you have more spaces in that barrier, and now the proteins can easily leak out, which is going to lead to nephrotic syndrome. Is that clear?
Yes.
Hello? Okay. So we discussed whenever we are seeing the word membranous, basically we are going to assume two things. First of all, we are going to be having thickening of the basement membrane. What else? We are going to be having deposition of immune complexes at the level of your glomeruli, which is going to lead to exaggerated activation of the local complement system, and in turn, that local complement system activation is going to lead to destruction of that barrier, which is going to lead to loss of your proteins, that is nephrotic syndrome. Is that clear? Hello?
Yes.
Yes,
Yes.
it's clear
So
now.
now let's discuss these pathology in detail, right? So the first pathology is going to be your membranous nephropathy. Membranous nephropathy, okay? So now we have the word membranous. So two things should just come in your mind. Yes, who is going to tell us those two things?
Is the first is the thickening and the other is the deposition of immune complexes.
Thickening and
Immune complex deposition.
deposition of immune complexes. So you already know the cause of this pathology. Immune complexes, they're going to come, they're going to lead to destruction of these barrier, and as a result of that, we're going to be having the nephrotic syndrome. Okay, so let's discuss in some more, like a little bit more detail. Why and which antigens are we most commonly going to see, against which these antibodies are going to be formed and these immune complexes are going to be formed, right? So usually here the cause is idiopathic again, right? And most commonly it's going to be seen in Caucasian adults, right? But the antigen which you guys can remember here is going to be hepatitis B, hepatitis C, and some tumors, and SLE. Some drugs as well, NSAIDs and penicillamine, right? So these are going to be the things which you have to memorize. On another way, simply you can think in some individual, whenever they have hepatitis B infection, hepatitis C, so the immune complexes can form, it can lead to membranous nephropathy. Whenever an individual is having SLE, as I just already gave you the example, in SLE we have complement deficiency, right? So the immune complexes, okay, which kind of immune complexes are we going to see in SLE? Antibodies against what?
Antigen.
Okay, what is going to be the antigen? That's my question.
Double stranded DNA.
Double
Antigen.
DNA. Okay, perfect. What
Okay.
else? NSAIDs. Whenever the immune complexes are formed against NSAID, in this way you can just remember it. Okay, so it's going to lead to membranous nephropathy, right? So there is a characteristic finding which basically confirm the membranous nephropathy. And what's that characteristic finding? Yes, these immune complexes are going to be present subepithelial, right? As we know that we have base membrane, okay, we have endothelium, we have a basement membrane, the podocyte processes. These podocyte processes are basically the epithelium, right? Epithelium. So what happens that these immune complexes are going to be present here, right? Subepithelium. What do you mean by subepithelial? Below the epithelium, right? Okay, and it's going to lead to formation of spike and dome appearance. So let's discuss the concept of spike and dome appearance. Okay, that's very simple. For example, if this is your basement membrane and these are your podocyte processes, right? So normally your epithelium loves to stay in continuation with your basement membrane. Okay, mark my words. Your epithelium love to stay, in close proximity or in continuation with your glomerular basement membrane. But for example, if now we have some immune complexes deposition here, right? Immune complexes deposition here. So what these immune complexes are going to do, they are going to push this epithelium, far away from the basement membrane. And what this epithelium in turn is going to do, it's going to grow more all around these immune complexes in order to maintain that continuation, right? Are you guys getting me?
Yeah.
Yes.
Okay. What the immune complexes are going to do, they're going to push the epithelium little bit upward. But we already discussed this epithelium loves to stay in continuation with your basement membrane. So what this epithelium is going to do, it's going to grow all along the sides of these immune complexes and it's going to attach itself again. It's going to maintain the continuation with the basement membrane. So in this way, you guys can see this kind of appearance, and whenever this is this appearance is visualized on electron microscopy, so you are going to see spike and dome appearance. That is a dome and a spike, a dome and a spike, a dome and a spike. So whenever in some question you see that on electron microscopy we were having a spike and dome appearance, so what should be your diagnosis? Yes,
Membranous.
membranous nephropathy.
Membranous.
Okay, whenever they are just telling you, you have an individual, he's having a history of SLE, okay, he's having a history of hepatitis B, a Caucasian adult, what should be your diagnosis again? Membranous nephropathy, okay? What else? What do you guys think? What would be the response towards steroids? Would it be poor or would it be good? Yes. Hello?
It
Yes, we're here.
look like good, because it's also inflammatory process with we. And
Okay. But if here the inflammatory process is basically due to hepatitis B, hepatitis C, SLE, So do you think if you are giving steroids, if you are further depressing the immunity, I think it would be a poor response because this individual is already immunocompromised. He's going to be having hepatitis B, C, tumors, SLE. So won't you think that the steroid response is going to be poor?
no.
Why don't you think that the steroid response, if you're administering steroids, so it's going to be poor? not poor.
Due to the immunocompromise, though, but my logic was that behind this, maybe it's not this on the membranous, there is some inflammatory process, going on. Maybe it's worse.
Yes, on the level of your glomeruli, we are having an inflammatory process. But looking towards the cause, it's basically association. Looking towards the association, it's associated with hepatitis B, hepatitis C. So in that case, if you are giving steroid, we are further worsening the condition of this patient. Okay, so the steroid response is going to be poor. Does it make sense?
Yes. Thank
Okay.
you.
Okay. Perfect. So the next pathology which we are going to discuss is membranoproliferative glomerulonephritis. Again, looking towards the word membranous, you know two things, right? We are going to be having thickening of the basement membrane, and this pathology is going to be due to, deposition of your immune complexes, right? Proliferative. What do we mean by proliferation? It means that in this pathology, we are going to see proliferation of something, right? Okay, I'll be discussing in detail what's the proliferation, what's that something, okay? So, membranoproliferative, we are going to be having proliferation of something, and that something is going to be your mesangium, okay? So, do you guys know what is mesangium?
No.
Okay, let me just tell you. You have your glomeruli, right? The glomeruli basically are having some supporting cells in between them, right? All of the glomeruli are having some supporting cells. Those supporting cells are basically known as your mesangial cells, right? Is that clear? So in this pathology, we are going to be having proliferation of those mesangial cells, okay? Which is going to lead to glomerulonephritis. Glomerulonephritis. The glomeruli is going to become, kind of inflamed, okay? Is that clear?
Yes.
No?
Yes.
Okay. So again, we have the word membranous. So two things just come into my mind. That is thickening of the basement membrane. And what else come into our mind? That is going to be due to immune complexes depositions. Okay, two things. Okay, so another thing which you should just keep in mind, there are two variants of this pathology, the type 1 and type 2. Okay, we have two variants of this pathology, type 1 and type 2. Okay, so let's discuss type 1 in a little bit detail. Again, we know the cause, right? The cause is immune complex deposition. Again, whenever the immune complexes are deposited, we are going to be having exaggerated activation of local complement system, which is going to lead to problems, right? So in type 1, these immune complexes are going to be depositing subendothelial, right? So for example, if it's a basement membrane, your podocyte, you have your endothelium, right? So the immune complexes in case of type 1 are going to be depositing here, right? Subendothelium. Is that clear? Hello?
Yes.
Hello?
Yes.
Okay. And this variant is going to be having association with hepatitis B virus and hepatitis C virus. That's really important. Keep that in mind. Okay. Okay. And in case of type 2, again, it's again due to deposition of your immune complexes. But this time, the location of these immune complexes are different. For example, if this is your basement membrane, your podocyte processes, so these immune complexes are going to be present in, intra, okay, in the intra or into, right? So type 2, the complexes are into the basement membrane. Is that clear? So type 2 stands for into, right? So the immune complexes, whenever are present intramembranous, right? In between the membrane, intramembranous, so that's going to be your type 2. So type 1 and type 2 basically differs by the location of immune complexes. In type 1, the immune complexes are going to be present below the endothelium. In type 2, they are into the basement membrane. Is that clear? Hello?
Yes.
And as we discussed that we have your mesangial cells, right? And we are going to be having proliferation of those mesangial cells as well. So what happens when the mesangial cells get proliferated? So what would they do? They would just cut these immune complexes into half. As they are growing, they would pass through these immune complexes and it would cut them into the half. So on imaging, or your electron microscopy finding, what we are going to see, we are going to see something like that. Okay, so this is your basement membrane. It's being cut in two parts, right? Why? Due to proliferation of your mesenterium, it's cut in two parts, and simply you can assume that some part of immunoglobulins are present like that, some of them like that. Okay. Hello. So you guys can
Yeah, that's what they call it,
on
Yes.
splitting.
sorry, what's your question?
That's what they call it. No, that's what they call it, splitting.
Yes, splitting. You can simply say it's split, but there is a characteristic word used for that. That is tram track
Tram
appearance.
track.
Right? Tram track appearance. Like you are going to see a formation of a track, right? A track due to proliferation. So whenever you see tram track appearance, right? Okay, so you can simply assume they are talking about membranous proliferative glomerulonephritis. Is that clear? Hello?
Yes.
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 Okay, perfect. What else are we going to see in this pathology? Just keep that in mind. As we already discussed, whenever the immune complexes are deposited, it's going to lead to exaggerated activation of the complement system, right? We know how do we activate the complement system. Whenever we have activation of C3 convertase, it's going to activate your complement system, right? Activate your complement system, the C3 convertase, right? Okay. So my question for you guys is that we are going to be having a specific factor that is known as C3 nephrotic factor. So what is C3 nephrotic factor in this pathology? It would stabilize the C3 convertase. And once the C3 convertase is stabilized, right? So it's going to convert more C3 into your, into membrane attack complex. We'll be discussing the entire complement pathway in our immunology section, but keep one thing in mind. The main enzyme or the main event in the complement system, we are going to be having three pathways: the alternative pathway, classical pathway, and the mannose binding lactate pathway, right? So the main goal of all of these pathway is, in the end, they should activate your membrane attack complex, and the C3 factor is going to be converted. It's going to activate your C5 convertase and everything. So C3 is the main event. Keep that in mind. So if we have a nephrotic factor which stabilizes this enzyme, C3 convertase, so it means we are going to be having exaggerated activation of your complement system. Am I right? Or
Yes.
overactivation of your complement system.
Yes.
Okay. So let's summarize this pathology once again. Okay. Okay. Let me just choose someone who can just summarize it for us. Dr. Jamil. Dr. Jamil, can you just please summarize this pathology for us?
Which one, sir? This one.
Right from beginning.
Membrane.
Membranoproliferative glomerulonephritis.
Yes, membranoproliferative. There is thickening of the membrane due to proliferation of some proliferative process in glomerulonephritis. This is due to the deposition of the immune complex, maybe inside the endothelium, and sometimes it's into the basal membrane.
Okay.
There's two types depending upon this deposition of the immune complex. If in type 1, it means these are these immune complex, they are deposited to the vascular side, means the subendothelial. And in type 2, they penetrate more further into the basal membrane, GBM. And due to this immune response of the mesangial cells, they split the immune complex into two parts, and that causes the splitting of the GBM, glomerular basement membrane. And in on electron microscope, it shows like trom track.
Perfect. Okay, it's perfect. So you guys can see that the type 1 is associated with hepatitis B and C. Okay, we already discussed that association of type 1 with B and C. So what do you think? Would the administration of steroid help or not? There would be a poor response.
I think no.
Again, pure
No.
response also.
Poor response.
Poor response. Perfect.
Yes.
Again, because it's associated with certain pathology in which already we are going to worsen if we are giving steroids, if you are suppressing the immunity. Okay. Is that clear?
Yes, sir.
Yes.
Thank you.
So the other pathology which we are going to discuss is diabetes mellitus, right? So diabetes mellitus. Remember, diabetes can also lead to nephrotic syndrome. How? Just keep that in mind. In diabetes, what are we going to see? We are going to see more glucose, right? Because due to the insulin isn't functioning, so what would happen? It would lead to more glucose within the blood, right? And whenever we have more glucose, it would lead to a process which is known as NEG, non-enzymatic glycosylation of your blood vessels, right? So just keep one thing in mind. For example, if this is our afferent arteriole, our glomeruli, our efferent arteriole, so these non-enzyme, okay, what do we mean by non-enzymatic glycosylation or glycation? Keep one thing in mind. Whenever the glucose is present in a high quantity, so non-enzymatic glycosylation means that without using any enzyme, this glucose is going to react with the surface or with the endothelium of different blood vessels, right? So the efferent arteriole is going to be the first target for this non-enzymatic glycosylation in cause of diabetes mellitus. In case, okay, is that clear?
Yes.
Okay, so what would happen as a result of that? The non-enzymatic glycosylation of efferent arteriole in the is going to lead to sclerosis, right? You're going to see, hyaline deposition. If you guys remember, right? Diabetes was causing your hyaline arteriolosclerosis. Remember, due to non-enzymatic glycosylation.
Yes.
Cardiovascular.
In
Yes.
cardiovascular, we learned these things.
Yes. Okay, so hyaline is going to deposit there in the efferent arteriole. Okay, if we are sclerosing the efferent arteriole, what happens to GFR?
It will increase.
Yes, it would increase.
Increase.
And as the GFR increases due to the hydrostatic pressure increase, what would happen? It's going to lead to hyperfiltration, right? Hyperfiltration.
Yes.
And that chronic hyperfiltration can lead to loss of your albumin as well, right? So the first thing which we are going to see in diabetes mellitus is hyperfiltration and albumin seen in your urine. This is going to be one of your UWorld MCQ. They're going to ask you, we have a lady with diabetes and there is going to be a selective albuminuria, right? Due to hyperfiltration, keep that in mind. But as the time passes, this sclerosis or non-enzymatic glycosylation is also going to move towards your glomeruli, right? So then in the end, we are going to have sclerosis all over the glomerulus. Sclerosis all over the glomerulus. And these sclerosis is going to appear as a nodules, right? Nodules within the glomeruli. And those nodules are basically known as chemal steel Wilson nodules. These are going on the histopathological slides. They're going to appear as a pink big nodules, right? So this is also going to be one of your UWorld MCQ. They're going to ask you that. They're going to give you the picture. Patient with a history of diabetes, with a history of albuminuria. And this is the slide. They'll just give you a big pink kind of nodules. What's the finding? It's basically your chemal steel Wilson nodule. Is it clear?
Yes.
Hello?
Yes.
And in
Yes.
Yes.
case due to hyperfiltration, if you are losing albumin. So can I list this pathology in nephrotic syndrome as we are losing proteins? Yes. Okay.
Yes.
Okay. So, and a really important concept which we should discuss here is that administration of ACE inhibitors. For example, if we have a lady or an obese lady having diabetes mellitus, again, she developed some, some kind of hypertension. So the best treatment option for that is going to be ACE, ACE inhibitor. Okay. Why? Why? What's the reason behind that? If you guys remember that the ACE inhibitor, it would inhibit the formation of angiotensin 2, right?
Yes.
Angiotensin 2. And we know that normally angiotensin 2 constrict your efferent arteriole. The mnemonic for that was ACE, right? Angiotensin 2 constrict efferent arteriole. So the efferent arteriole is already sclerosed. We are constricting it, due to sclerosis, non-enzymatic glycosylation. So in order to avoid that extra constriction by angiotensin 2, the best drug of choice here is going to be ACE inhibitors. Does that make sense?
Yes.
Okay. Hello?
Yes. Hmm.
Okay.
Yes.
So ACE inhibitors are going to be used in this case. Okay. So this was all about the diabetes, and you should know the efferent arteriole is going to be the first one which is involved and is going to lead to this process. Okay. I think that was simple. So now we have the last pathology of your nephrotic syndrome, the last pathology. Okay. Nephrotic syndrome. That is going to be systemic amyloidosis, right? Systemic amyloidosis. Before discussing systemic amyloidosis, let's discuss a little bit, about what is, polarized light, what is plain polarized light, and everything. Okay. So keep one thing in mind. Do you know what is plain polarized light? Anyone? PPL. These are some concepts from our basics physics. Okay, if you guys remember, there were a topic of prisms and diffraction and everything. Do you guys remember that? Hello.
Yes, sir.
Okay. So
It is
remember,
a type of light in which all waveforms are in same direction.
perfect. Yes. So normally the light travels in every direction, right? So sometimes what we do, we just keep slits in the front of light, and we just pick only a single plane of light, right? A light traveling in a
Like a
single.
laser type.
Yes, a laser kind or a pinpoint or
Yes.
a focus kind of light, right? So whenever this plane polarized light falls on certain crystals, right? Or whenever it falls on crystals, they're going to give you characteristic, colors, different wavelength colors, right? So like the crystal is going to allow only the reflection of certain wavelength, and the certain wavelength color are different, right? So the colors have different wavelength. Keep that in mind. So this concept is going to be used here in amyloidosis, right? So what we do in amyloidosis, we are going to be having deposition of amyloid. What is amyloid? Simply, you can just think of amyloid. We are going to discuss amyloid in detail, but amyloid is basically a kind of disorganized proteinaceous structure. Disorganized proteinaceous, particles of structure. So normally in the body, whenever we have some disorganized, proteins, and they build up in your blood, they are going to deposit in different tissues in the form of amyloid, right? That simple thing for now, you can just keep it in mind. So sometimes this amyloid can deposit in your mesenterium as well, in your glomeruli as well. And once we have deposition of that amyloid within the glomeruli or the mesenterium, what would happen as a result of that? It is going to lead to amyloidosis. And amyloidosis further lead to nephrotic syndrome. Okay? Is that clear?
Yes.
Yes.
Amyloidosis further lead to nephrotic syndrome. How are we going to diagnose? How are we going to confirm that yes, it is amyloid? Because we know amyloidosis lead to nephrotic syndrome. For that, what we are going to do, we are going to, again take the plane polarized light. We are going to fall at this plane polarized light on the to the amyloid, right? But before that, we are going to stain this amyloid with a Congo red stain, right? Okay. So if you are just suspecting amyloidosis, so just take the amyloid simply, just stain it with Congo red stain, and just pass the plane polarized light to it. If we see a green color, right, that is a green, apple green birefringence, so it's confirmed that we have amyloid, right? Okay. So you're going to be having a lot of MCQs in your NBMEs, in your UWorld. They're going to ask you, we have apple green birefringence under polarized light after staining the amyloid with Congo red stain. What's your diagnosis? Amyloidosis. If it's in case of kidney, it's going to lead to which pathology? Nephrotic syndrome. What is nephrotic syndrome? Losing more than 3.5 gram of proteins per day. That's all about nephrotic syndrome. Do you guys have any questions? Hello?
Yes, I
No, sir.
do. I
Yes.
do. Please, can you explain again how diabetes causes causes increased glomerular filtration rate? I didn't understand it.
How diabetes cause increase?
Causes elevated sugar causes in the kidneys. It will cause increased glomerular filtration rates with deposition of sclerosis in the afferent arterioles.
Okay, sure. So whenever we are having diabetes, so the glucose is going to undergo non-enzymatic glycosylation, right? So let me just draw it here. If it's our afferent arteriole, our glomeruli, our efferent arteriole, right? So for example, if you have a lot of glucose present here, so it would react with your endothelium without using an enzyme, which is known as non-enzymatic glycosylation. Okay. And as a result of that, what happens? We are going to have deposition of hyaline here, right? Hyaline is basically a protein present in your plasma. It would just come out and it would just deposit here. So once it's deposited in the efferent arteriole, the efferent arteriole is going to become sclerosed, right? Or it's going to, become obstructed with that presence of, or we are going to be having hyaline arteriolosclerosis. Is that clear till now?
Yes.
Okay. Non-enzymatic glycosylation is going to lead to, coming out all of your hyaline. Your hyaline is going to obstruct your efferent arteriole. And once the efferent arteriole is obstructed, okay, simply you can assume that now efferent is constricted or obstructed. So all of the blood is going to pull back, right? And as the blood pull back, the hydrostatic pressure of the blood would increase. And as the hydrostatic pressure increases, the Starling forces we discussed in details, it's going to lead to more GFR. It's going to lead to more GFR, glomerular filtration rate. And if it's chronic, increased GFR, increased pressure of the blood, there is going to lead to some damage of your barrier, and that damage can lead to albumin coming out through those damaged area, which is going to lead to nephrotic syndrome. Is that clear now? Hello?
Yes, it's very clear now. Okay. I understand it now.
Oh, thank you so much. So this was about our nephrotic syndrome, and I think the time is over. So, okay, so today we are going to share the schedule, right, from pathology, and after that, what we are going to do, we are going to discuss the U world from tomorrow onwards as well, right? So let me just share the task for today. Hope so you guys enjoyed the session. Did you guys enjoy the session with me? Hello.
Yes,
Very
thank
much,
you.
very much.
Yes.
Thank you so much. Thank you so much. And I'll be just sharing the recordings in a while. I'll be sharing the schedule in a while. And from tomorrow onwards, tomorrow we are going to discuss a really important topic, that is acute renal injury. Along with that, we're also going to be discussing our nephrotic syndrome. Okay, so nephrotic syndrome is again going to be really fun for you guys. And again, I'm going to tell you certain, hacks in order to, remember all of these pathology and everything. And we are also going to discuss U-World as well. So from tomorrow onwards, we'll be having a regular U-World session after this class as well, okay, with me. Okay, thank you so much.
Thank you.
And have a nice day.
Thank you.